Top Med Talk.
Nick Majerison here, welcome to Top Med Talk. This piece is in 4 parts, and this is the second of them. It's called the Perioperative Cognition Workshop. It took place at the Australian and New Zealand College of Anaesthetists earlier this year. The other parts to this piece are available on topmedtalk.com if you check in the show notes for this podcast.
So, having set that stage, what I want to go through with you now is how you would differentiate in the that acute post-operative phase, up to a week, maybe even longer, between the delayed neurocognitive recovery, and one of those examples, a 54-year-old anaesthetist would be an example of that, or post-operative delirium, and the elderly gentleman had a clinical example of that. And also we need to be a bit reassuring. Just about everyone going through anaesthesia and surgery, particularly of the younger age group, in other words, below 60, 65, I think that's important to have that threshold, has an uneventful recovery. They do well, they recover quickly, they improve because of the functional benefit of their surgery, and they go on to live their life unimpacted. The problem is in the older population, as you can see down the bottom there, there is this significant risk of delirium, up to 50 to 60% in the post-operative period, and there is also this significant risk of delayed neurocognitive recovery, which was called POCD in the past, and we were trying to classify that as early POCD, but I think now it's better to call it delayed neurocognitive recovery.
Reflecting the fact that patients are in a period of recovery.
Of flux, yeah. And then moving on to the period of months to up to 12 months, it would become NCD post-operatively or post-operative NCD. And then as this may progress, and we'll talk about Liz will present some of the data later of what that might mean from the point of view of longer-term cognitive change. So really the core group there is perhaps what can we do to impact this large number of people in the short term, and noting that still there's a residual of currently there's 10% or so of older patients who do have measurable cognitive decline at some months after anaesthesia and surgery and hospitalisation. So we'll focus. So this is a cognitive graph. So basically, this is what the patient brought. This is cognition on the y-axis and time on the x-axis, and basically what their cognitive level when they came into anaesthesia and surgery. They had their anaesthesia and surgery and hospitalisation and stress. Then they make a recovery, and we're focusing for the point of view of the short term around about here up to day 30. And recognising, and this is part of a different, longer discussion, that patients may be on a trajectory of decline, and we may just be seeing a brief dip and then they return to that further decline trajectory. And that older patient may already have been on a trajectory of decline, and the anaesthesia and surgery stress unmasked that, but actually they didn't, but they got back to where they were, but it was obvious they weren't coping well with the extra limitations post-procedure. But again, there's some evidence that Liz will present which suggests that having had episodes of delirium in hospital actually can make that trajectory steeper. So POCD is this difference here after that period of time, which we were measuring, and now we would call it neurocognitive disorder, where you'd expect to where they are. So this is data from a number of studies listed on the right, showing the percentage of calculated POCD, and for the purpose of this discussion, I'm calling it delayed neurocognitive recovery, in the week post-operative. It's quite high, and it does relate to the intensity of a procedure. It does relate to the amount of stress, pain, surgical stress, ICU stay, and so cardiac patients have more early, what we used to call early POCD, but now we would call delayed neurocognitive recovery. But mixed into this group and mixed into a lot of these studies has been delirium. And a lot of the studies in the literature didn't distinguish or separate between the two. And hopefully with the new nomenclature we can now. But you can see that, as you know, elderly patients having fractured neck of femur are at very high risk of having delirium in the acute post-operative recovery phase. And we'll talk a little bit about the hypoactive and the hyperactive forms a bit later, won't we? And also, but other patients having other procedures are at high risk as well, including obviously in intensive care. So that wasn't separated. So what we're going to try and do is just help clarify what the difference is, if we can, between delayed neurocognitive recovery and delirium, and the features and characteristics and risk factors. So this is a bit of hand showing. So these are some features of cognition that you might see in a patient post-operatively. So we've all seen emergence excitation in PACU. Hands up if you think that is actually a variant of POCD, or so let me call it DNCR from now on, or delirium. So who thinks it's POCD? Come on, be brave. Okay, there's about 5. Who thinks it's a form of delirium? Yeah, majority. And look, on talking to our psychogeriatric colleagues and the delirium experts, they would say, well, you know, it does meet the criteria for delirium, but it's different, isn't it? It's often in young patients, young males, children even, having emergence excitation. It's not quite the same population dynamic. So whilst it can meet the technical definition of delirium, there's still some debate about whether that delirium, that episode of emergence excitation, has a similar impact as an episode of delirium on the ward later on. So I've put a question mark there. Confusion. Is confusion characteristic of DNCR or delirium? So we'll take delirium first. Is confusion part of delirium? Good. Okay. Majority of rules will accept that one. Fluctuating conscious state. So some time of the day they're good, some time of the day they're not good, and it's quite distinct, different change over time. Do you think that's DNCR? Who thinks it's DNCR? Fluctuating conscious state? There's a few, perhaps about a quarter. Who thinks it's delirium? Excellent. We didn't need to do a consensus paper. We've got the answer in the room. Forgetfulness. Memory problem. Who thinks that's DNCR? Who thinks that's delirium? Correct. So memory problem are one of the 2 major problems associated with delayed neurocognitive recovery and later on neurocognitive disorder or decline. Concentration, inability to pay attention, to focus on a task for even a short period of time. Who thinks that's to do with delirium? Who thinks that's to do with DNCR? More for DNCR, but in fact, lack of attention is a characteristic of delirium. It's one of the diagnostic criteria of delirium. Coming on acutely, both of them come on acutely, so that's what we've been talking about. The ability to plan things, high-level thinking. Again, it gets in towards this IODL thing, but what we call executive function, in other words, planning ahead, working out what you're going to pack for the trip the next day or what part of your meal to eat first. Who thinks that is a delayed neurocognitive recovery? Good, about 2/3. Who think it's delirium? Less, about 1/3. And yeah, it's more characteristic. It's a decline in executive function. And these 2 things are probably the most common forms of delayed neurocognitive recovery. And agitation on the ward. Who thinks it's delirium? And you're quite right. Remembering that's only one manifestation of delirium.
And I mean, the other thing to be conscious of is that whilst we've divided those up sort of separately, there are overlaps between.
Yeah, and that's the problem, and that's a challenge, because if you've got someone who's acutely delirious and you apply test methodology for NCR, they would probably fail. But the cause is probably more clinically delirium, and the research at the moment is into delirium in terms of prevention. So what test would you throw at this? And there's a lot of people would say, oh, MMSE. We know MMSE. We've heard about the mini-mental state examination. It tests a whole lot of things. But it's not appropriate for this type of assessment in the acute phase.
For either delirium or for DNCR?
Yes. It's a tool designed to detect cognitive decline, particularly designed to detect the cognitive decline associated with dementia. This is just an example of some of the tests there. There are 30 points you can achieve with a mini-mental. Less than 24 indicates a high probability of having some form of dementia, and remembering dementia is a spectrum. But it does have a ceiling effect, so even patients with mild cognitive impairment may score adequately on a mini-mental. So it doesn't detect mild forms of cognitive impairment very well. So the more impaired the patient is, the more clear an answer will be from the MMSE. So its sensitivity is relatively low, and some have rated its sensitivity even down at 18%. But its specificity, if it is positive, it's quite likely they've got a memory disorder. And it's not those things. It's not POCD, it's not DNCR, it's not post-operative. So MMSE is not the tool to be applying in that context as a screening test. So delirium, as we talked about, we've defined it already. It's an acute change or a fluctuating course of mental state. It features inattention, and it also features either an altered level of consciousness or disorganised thinking or confusion. And it's defined in the DSM. It already exists there. And there are screening tools for it. Are you doing this now? Still me? Okay. So, just checking. We will come to these screening tools actually later, won't you? You'll be talking about these. So there's diagnostic tools such as the confusion assessment method, or the CAM, which can be applied in ICU as a CAM ICU, but they take skilled assessors and they've got quite significant criteria to be met and take a little while to administer. On the right there is the 3D CAM, which we use in our clinical research. That requires trained assessors, but the training is relatively straightforward and can be done using an online module. But again, you need to sit down and take your time, and you need to be careful about how you observe the characteristics and sensitive to the characteristics of the patient. So we then come to the 4AT, which Liz will talk about later, which is a screening test for delirium. So we've identified that delirium is a problem. It's common in elder patients. It's not a transient inconvenience. It is associated with delayed discharge, complications after surgery, increased risk of dependency and discharge to higher levels of care, is associated with dementia, and dementia is associated as a risk factor for delirium. And it is associated with, if you have episodes of delirium post-operatively, you have a higher mortality in 3 months and at 12 months and even longer. And it costs a lot to healthcare dollars. And we were talking a lot about healthcare economics yesterday, particularly at the strategy meeting. But in the US, it's estimated roughly $26,000 per patient costs. In Australia, the economic analysis is it's roughly 10% of the total cost of that patient care episode extra for an episode of delirium. So it's quite an expensive healthcare burden. Estimated to be able to be prevented in 30 to 40% of patients.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.